Welcome to our monthly physician to physician call with our County Public Health Officer, Dr. Cameron Kaiser. Dr. Kaiser, our colleague and public health officer for the county, has been working extremely hard and diligently and tirelessly for almost a year in our fight with COVID-19. We always have enjoyed and learned a lot from his inputs, updates, and guidance. Let me hand it over to Dr. Kaiser. Good evening, Dr. Kaiser.
Thank you, Dr. Singhvi. I'll go ahead and do a brief update beforehand, and then we can jump into the questions. Today, Riverside County added 646 new cases and 23 deaths for 284,814 cumulative total cases, 243,607 total recoveries, and 3,477 cumulative deaths. For those of you keeping track at home, that is a crude case fatality rate of 1.2%, just saying. At our peak during the winter surge, we had over 1,600 COVID-19 positive inpatients, over 3 times the peak amount we had during the summer surge. And even now, we still have 687 inpatients, 194 of them in the ICU, both of which also exceed the summer peak as well. Unfortunately, a fair number of the discharges are not people going home, and we expect to continue to record elevated numbers of additional deaths for at least the next couple weeks, including ones in the community. Of these deaths, the greatest risk factor continues to be age, and the number of male deaths is about 60% higher than female deaths. In terms of absolute figures, the majority of our cases occur in the 25 to 44 age range and slightly more females than males, but the majority of our deaths are 65 to 84. While our positivity rate has slid considerably from its peak of over 25% in early January, our most current positivity rate is still well above 12%. I know we have a lot of questions on vaccinations, and some of them are actually asking the same question in slightly different fashion. So I will largely concentrate on statistics here, and then we can talk about the policy and procedural issues during the question and answer section. On our COVID-19 dashboard, we've administered a fair amount of the 296,875 doses we have received. There are only 15,776 doses left yet to be administered, and even this number is almost certainly an overestimate due to data reporting delays. We have almost 90 hospital and community partners already registered who have received 158,150 of those doses. That actually directly speaks to a question later. And starting next week, the allocations will be entirely based on age. We expect to receive 6.19% of the state allocation based on our approximate 365,000 residents over age 65. Granted, at roughly 1 million doses a week coming to California right now, that is not a lot. But you will have doubtlessly heard about Governor Newsom's new third-party administrator plan, which will centralize vaccine distribution and rollout. And this administrator was recently announced to be Blue Shield, which previously worked with CDPH on testing innovations way back in the distant past of 2020. Blue Shield has chosen to divide up the counties into various waves. We in Riverside County are actually part of the first wave, and over this holiday weekend, we will be having meetings with Blue Shield to discuss this in future allocations, especially in light of equity issues, where other counties previously have received per capita allotments that were greater than ours. Now, part of this can be explained by differences in the relative sizes of the healthcare workforce, but the healthcare workforce is not the only determiner of those numbers, and we do intend to strongly advocate for Riverside County's fair share going forward. That said, the final decision is Blue Shield's, and we'll advertise publicly when we know what those numbers going forward will be. On the national side, the CDC made 2 notable announcements this week, one about double masking and another about quarantine requirements for the fully vaccinated. In the February 10th issue of MMWR, the CDC experimentally assessed 2 ways of improving the fit of medical procedural masks, which are, of course, the minimum standard for clinical PPE. As a baseline, standard 3-ply procedure masks, your typical medical mask, blocked approximately 42% of particles from a simulated cough. A 3-ply cotton cloth mask, and I grant there are large numbers of variation in those types of masks, but it blocked about 44.3%. The combination, however, of the cotton mask covering the clinical procedure mask blocked 92.5%. When the source was masked and the receiver was not, adding a cloth mask to a procedure mask blocked exposure by the receiver by 82.2%, and even simply knotting the ear loops and tucking in the sides of procedure mask blocked exposure by 62.9%. When the source was unmasked and the receiver was masked, and this is probably a more typical situation in many of our clinics, even though patients are supposed to be wearing them anyway, nodding and tucking reduced exposure by 64.5%, but double masking by 83%. If both of them were double masked, then the exposure of the receiver was reduced 96.4%. If both were knotted and tucked, it was almost the same at 95.9%. Now, these numbers, of course, vary depending on the mask, and while 3-ply masks are relatively standardized, cloth masks, of course, are not. Still, in every case, the combination yielded better protection, and the authors believe that the major mediator of the protection is better form-fitting to the face. So mask fitters and nylon coverings over the mask, even something as simple as a tight ring cut out of pantyhose, and they specifically mentioned that in the article, would likely have similar benefit. Nothing requires double masking now, but there is at least some experimental evidence to suggest that it really does make a difference, so it is now an option that you may consider. The second announcement, which I know a lot of you have heard about, regarded quarantine for fully vaccinated people. Basically, the CDC said it should not be necessary if you are fully vaccinated, i.e. at least 2 weeks after the last dose in the series, whether it's 1 or 2. So if it's Johnson & Johnson, when that gets approved, then it would be 1. You got that last dose in the last 3 months and you are asymptomatic. As usual, of course, the press got it wrong. They concentrated exclusively on being vaccinated, but that is not what the CDC said. The story in the press is if you're vaccinated, you don't need a quarantine, and it's not really that simple, especially with the new strains and some questions about how effective the vaccines will actually be against them. It really can't be. And that's probably why they have that last dose in the last 3 months proviso, because we really don't know what's going to happen at that time frame. And it's entirely possible that a more resistant strain may have achieved dominance by that point, which would make the vaccine strategy less effective. I do think that it's a logical step to take. After all, we don't quarantine people exposed to measles who got their full series. And measles is clearly more contagious than COVID-19. But on the flip side, we don't have a whole lot of trouble with aberrant measles strains either. And of course, this assumes that people actually do quarantine when we tell them, which is impossible to follow up on when we're adding hundreds of new cases daily, but I'll be optimistic for the sake of argument. We do have to be mindful of the question over this in future mutations, however, and resist the urge to stop being cautious. And I should also stress that this is not clinical practice right now. Even though the CDC makes recommendations, and they make many of them, it's states that are responsible for operationalizing them. The CDPH is the one that does the binding guidelines. They are reviewing it, but have not come to any particular decision. So until they do, quarantine guidelines remain the same. You may hear about this as early potentially as next week. We have brought it to their attention. I know a lot of people have, but until they do, and it's situation normal as far as quarantine goes, even with people who've been fully vaccinated. With that, Dr. Singhvi, I will hand it back over to you for the questions.
Thank you, Cameron. The first question is, I have been told that individuals who received their first vaccine dose at a county vaccination clinic have no idea how to be sure they can receive their second vaccination 28 days later. So how can they definitely schedule their second vaccine dose on time? Does the county have any intention of changing this policy?
The answer to this is yes, and we actually already have. But let me advise you of 2 current things that are going on. First, as I mentioned, and this goes along with the whole Blue Shield question, the state is taking an extremely centralized approach, including with the new third-party administrator. And the official state policy is a dose is a dose. The state wants us to allocate in terms of absolute vaccinations rather than separate pools. They are saying we can predict ahead for those people who need a second dose on a week-to-week basis. And we are trying to work with that with the proviso we don't have a clear understanding of our total future allocation. All we've got right now are estimates. And the state also does indicate that we should prioritize completion of series when there is a shortage. So with all that in mind, we do absolutely have second dose clinics. We were posting them already. We're opening up 15 pure second dose clinics in the next wave with about 16,000 appointments. And we are also, after people get their first dose, they are taken to a special area where they can plug people in and get their second dose scheduled on the appointments that are presently available. Now, I will be to the point on this, though. We are also getting into those second dose clinics people who probably shouldn't be there. There are a substantial number of community providers who are not doing second doses themselves and instead punting them to the county. We've gotten a fair number of signups from people who state they got their first shot somewhere else, but that site told them they won't do the second dose, so we have to take up that slack. Now, I'm fairly certain this is not the majority of providers, but nevertheless, it is still something that's affecting our ability to even get the ones that we do first in a timely fashion. I want to stress, though, that that is not our policy going forward. We do want to make sure that people finish the shots. We believe this is important. Within the limitations that the state places on us, that's what we're endeavoring to do.
Thank you. What is the best way to get vaccines at a primary care clinic? Can you please go into detail the plan for private medical offices to register to obtain the Moderna vaccine in preparation to administer our patients and as recommended by CDC? The state retired the CA COVID Ready portal last week. We were then directed to another portal this week. However, registration through CalVax is solely for state and local health departments. Please advise or direct us who to contact for additional information. CDPH refers us to the county, and county is currently directing us to the retired portal.
CalVax actually is not just for state and local health departments. And let me put an address here so that if you're sitting in front of your computer, you can see what I see. This address, if you go there, you'll see the entire process. You enroll as a provider with CARE, the immunization registry. You attest that you have the storage capability. You complete the provider enrollment worksheet, which is what it's literally called. It is intended for all providers, whether they're government or not. Get your sign-offs from your CEO and your CMO, and set up your training and submit. And right now, CalVax is the only system. You don't need to register with any others. That site, and I checked it today, has that whole process laid out right there. But if you are still having trouble with it, I'll enter a couple other ones here too. The State Department of Public Health does have a call center to assist with facilities. There's a telephone number. It's 1-833-502-1245. And there's also an email address, which is COVID call center at cdph.ca.gov, which I'll also put there as well. If you are having issues with CalVax, or you think you're on the wrong portion of the site and you can't register for it, you can go in through there and they will help you with this. We've had other providers who have been directed to it, but we have 90 community providers and hospital providers signed up already. So, I mean, that's the only process which has been done. We'll help you out as much as we can. If there's any questions, we're happy to do so. But the state can help you directly with this process also.
Thank you. Time permitting, Dr. Kaiser may be able to answer a few additional questions, so you can write any questions in the chat box. Next question is, I have a busy geriatric clinic taking care of 700 senior patients. Many patients are asking when and where they can get COVID vaccination. Can I apply to get vaccination allocation for my clinic? If so, how can I apply? I tried to do the CARE program, but it is not an easy process.
So let me reiterate, because a lot of this is going to be similar to the previous question, but just to point out one thing, CARE and CalVax are not the same thing. CARE is the state immunization registry. Now, you do have to register for CARE as part of the CalVax onboarding process, but anybody who administers vaccines, particularly peds, but also adults, should be entering administration data into CARE. But CalVax is how you actually register to receive vaccine. I grant that the process is somewhat bureaucratic. There are 6 specific stages which are displayed on the CalVax page. Part of that, though, are federal requirements. If you look, for example, at the provider worksheet, that is actually a CDC form. It's not CDPH. But we also understand that it has been a burden for many smaller clinics, and that HHS is attempting to streamline that process. But just to reiterate, CARE is not what you apply to actually get vaccine. CARE is what you apply to actually enter the vaccines that you've administered. You have to apply for CARE registration as part of the CalVax process, but CalVax is a separate system.
Thank you. Next question. There seems to be some inconsistencies about the vaccine rollouts. Some clinics are getting them and some are not, depending on facilities, and the public is only able to get it depending on their tier. Can you clarify what the protocol is from the county on how the vaccine is getting rolled out. Also, some facilities are sitting on vaccines but are not allowed to open up to the first responders like firefighters and police department. If so, vaccines are not being used and just sitting in storage. What is the protocol to get those out to the public?
I'm not sure how to answer this question in the general sense, so I'll just go piece by piece. If you know of a facility that happens to be sitting on vaccines, we can claw those back and redistribute them. So feel free to rat them out. That's fine with me. But I don't think there are many in this category. Blue Shield may do this also in their judgment, but we're not getting a lot of reports of wastage. And I don't think it's as large a problem as some media reports have made it out to be. The larger issue is that vaccine administrations weren't being entered, which tends to magnify this issue. And this has also polluted state level data, which we're hashing out this week. I'll also say, and I'll primarily leave it at that, we have had some polite but pointed discussions with a few providers who have vaccinated out of tier. I won't say more about that other than to say that we have had those discussions. But the long and short of it is, if you're certain that there is somebody out there who ordered a whole bunch of vaccine and isn't handing it out, by all means, bring that to our attention, because we definitely don't want it sitting around doing nothing.
Thank you. If a 75 plus year old is on the waiting list for a county clinic site, should he or she not also apply for an appointment at one of the partners like Albertson, Walgreen, Ralph's? Would that create duplicate confusion?
Actually, that's a great question. The waiting list doesn't really take away spaces from anybody. It's a waiting list, and it can deal with someone getting their shot elsewhere. If they have an appointment already with a partner, I would not then sign up for a waiting list slot. I think I'd avoid it in that situation. But if they have a waiting list slot with the county and then find out they can get in at Ralph's or something, then just go do it. We'll go to the next person in line. I don't anticipate it being a major big deal.
Do they need to cancel the other appointment or it automatically
Well,
cancels out?
this is a waiting list one. So they would, when their time in the waiting list comes up, they would still need to take an affirmative action to take a slot. So they just don't.
I see. I have patients that do not use the computer due to disabilities or age. What accommodations are available to help them schedule to get their COVID-19 vaccine?
This has been a real issue for us. The state is supposedly looking at call center options or other ways, because this also affects areas of the county where internet access is harder to come by. So it's not just an issue for our senior population, even though it is being felt most acutely there because they're the ones who are available in tier. I don't have a clear answer other than to say that we're looking at it. The problem, of course, is that this requires operating a large call center. And we're probably going to have to partner with the state to make this happen. I'm just going to say to be continued on that, and we'll be publicizing more about it as we get a firmer arrangement in place.
Great. Next question is there any progress happening with vaccinating children?
The main issue right now is that the EUAs for the Pfizer and the Moderna candidates, the Pfizer goes down to 16, but Moderna is 18 and up. There are some attempts to enroll for pediatric studies, but I know that a couple of places have even enrolled within Riverside County. We actually had a very angry school district asking why they were signing up in their neighborhood. And as far as we're concerned, that's not something they have to tell us about. That's done with the FDA. But I have not heard whether this is ready to publish any data. Obviously, like in adults where they're looking for evidence of efficacy, they're going to have to achieve a minimum number of cases within that population to make that dosing data reliable. And kids, the presentation does appear to be substantially different than that in adults. There'll probably have to be a lot more asymptomatic testing, for example. The long and the short of it is I am aware that the studies to get this data are going on, but I don't know when they're going to bear fruit, and I probably wouldn't anticipate opening it up to pediatric populations much before summer.
I see. Next one. I have a 16-year-old patient whose sibling has Down syndrome. She was told to get Pfizer vaccine. Where can she get it?
She is, as terms of the age range, being 16 and up, she could get Pfizer. But currently, the state puts individuals with chronic diseases into phase 1C, which includes Down syndrome. Now, the state does have this on its radar for not only Down syndrome, but other chronic diseases. And we have gotten a lot of requests from individuals to bend the rules. I will say that in most cases, when I am reviewing a request like that, I need to show that there is something with greater evidence of benefit than them before I reallocate a dose potentially from somebody else who actually is in the open tiers and phases. We don't have a lot of that data, unfortunately. And in many cases, with the shortage of vaccine there is, I'm probably just going to err towards age because that appears to be the greatest discriminator. But we do consider these requests, and we do expect that that data will start to come in as the studies start become less selective. They were very selective, particularly with the immunocompromised, to avoid, I think, causing issues as far as their perceived vaccine efficacy in a population that would possibly not have as robust an immune response as other people would. But it's also clear those folks need to be protected, and I know that there are studies enrolling to try and look at the issues with them particularly. Just be aware that right now we don't have enough present clinical evidence to just justify an override in most cases. As the supply improves, naturally we can be less stringent about that. But for the time being, if you have somebody you feel strongly would benefit and you believe that the evidence actually is there, by all means, bring it to my attention and we can look at it. Just keep in mind that I've basically got to be in a situation where I'm taking a dose from somebody else to give it to your patient. So please keep that in mind.
Thank you. 1 week after the second dose of Moderna and Pfizer COVID-19 vaccines, it is the understanding that the combination of these doses provides 95% protection. As a result, does this mean that those fully vaccinated people with documentation of the COVID-19 two-dose immunization can be exempt from wearing masks and COVID-19 testing requirement for public places, school, workplace, gym, dance studios, and for travel, etc.? I believe a new friendly policy regarding this issue would help to persuade a lot of people who are hesitant and on the fence about getting the COVID-19 vaccines to overcome their reluctance or hesitancy and to go ahead to get vaccinated and thus get their lives back to normal.
I think this goes into what I commented on during my initial briefing about the CDC statement. I think that there's a difference between exempting them from quarantine and then exempting them from other precautions, because what we don't know is how effective somebody who has been vaccinated is at spreading the disease. I'm sure most of us are familiar by now with the concept of sterilizing immunity, and also realize that for many vaccines, that is the exception rather than the rule. We believe that the viral load borne by somebody who's been vaccinated is likely to be lower, and therefore they are less likely to transmit it to other people. But we still need to be able to actually observe that in practice. Some of the Israeli data, and Israel is probably one of the furthest ahead in terms of vaccination in large-scale populations. And they're estimating somewhere around a 2/3 reduction in transmission, but that still means that they are at least able to transmit at least a third of the level as before, which could still be a concern for the medically vulnerable. I do appreciate what you're trying to say, that we want to give people every incentive to become vaccinated. And I certainly respect that. That's why I think that, particularly for eliminating the quarantine requirement, at least within the window where we believe it to be effective, I think is useful. I'm a little more hesitant about other precautions, though, because as you may have noticed, the vast majority of our cases are in the young ages, but the vast majority of our deaths are older, which means that the population least likely to, shall we say, adhere to these restrictions now is the ones putting that risk population at the greatest risk. And this is going to diminish their transmissibility, but not fully, at least with the information we have in front of us. I think I'd like to see more data about how well these reduce person-to-person transmission in the typical setting before at least I would be comfortable saying that to people. But I appreciate that we want to give everybody a good reason to be vaccinated. My question is, I'm not sure if we have enough evidence to say that should be the reason.
When will Riverside County allow schools to apply for a waiver to reopen? It seems we are near the case rate we were before when the county allowed schools to reopen.
There's two ways that schools can reopen right now. We are in the four color system. We're back in the purple tier, which is the most restrictive form. If a county enters the red tier, which is the second most restrictive, then schools can open at their leisure as they determine appropriately. In fact, we had about a period within the red tier for about a week, and many of the private schools went ahead and did just that. For the remainder, though, now that we're back in the purple tier, the state is requiring that the health department look at right now it's a COVID-19 prevention plan and a checklist, which the state issues. We have 7 business days to do so and register any objections. And the state may also register objections as well. I've already approved one school district to go ahead and move forward. Their plans have been signed off by me, assuming the state concurs, and they can just go ahead and get back into it. We are also looking at some other districts, but we're gonna hold them to the standard. And the simple reason is that I'm not trying to put too fine a point on it, but people are more than happy to hide behind the health department when there's an outbreak and say, well, you guys let us do it. So if that's the case and I'm in a position where I have to sign off to enable you to open, then by golly, you're going to do it to the letter. We're not asking anything more of them than what the state requires, but they are going to do what the state requires. Even that I'm having some discussions with superintendents about, and I won't belabor the point. But the long and short of it is I do want to get kids back into school, but I want to make sure that we get them back in as safe a fashion as possible, because if there happens to be an outbreak in a school, it's going to come back on me.
Very true. Next question is there a way to, one, create teacher-only vaccine days per clinics, two, have these clinics in South Riverside County, not just the North, and three, work with the school districts to create accountability lists of teachers who either have been vaccinated or who refused a clinic appointment. If we need state permission, can we lobby for this approach? If we have such a list, the unions will be less obstructive and will work to create a safe opening.
I'm not going to comment specifically on the union issue, except to point out that 16 unions recently wrote a letter to the County Office of Education saying that schools are opening up too fast. So I'm just going to leave that there. That letter was printed in the Press Enterprise, and you are welcome to read it. I'm not saying I agree with them or not, but just keep in mind that I'm not sure that this will necessarily change that position. That being said, yes, it is certainly possible to do so. Some of our schools are already setting that up, and we're happy to partner with them on that. Of course, this assumes that we have vaccine available. And as I mentioned, we will be almost certainly prioritizing by age because that is where the most mortality occurs. But as the vaccine supply increases, yes, I agree that schools should be a priority. And I think that the state does too. And we're likely to see them being moved over to that as we get more in stock. Secondly, as far as having clinics in South Riverside County, not just the North, absolutely. We're happy to have it anywhere we think that we would actually get the throughput. The third request is a little bit more problematic. The EEOC does say, and I'm not an attorney, so do not take this as workplace advice, but the EEOC does say that you can require people to be vaccinated as a condition of returning to work. Now, it does not say, however, necessarily that if you don't do that, then you can fire them. You may have to do other kinds of adjustments, and you may also have to consult with an employment attorney about exactly what level of workplace, what's the word I'm looking for, accommodation needs to be made in that situation, what you're actually legally liable to do. I also don't really want to turn this into a hit list of who's been vaccinated and who hasn't been, because there may be perfectly reasonable reasons why not. And in these highly charged times, there's lots of people willing to point fingers at other people for things that may be no fault of their own. But as far as the first two, I think those are eminently achievable. We're already doing some of this in a smaller sense already. And as we get more vaccine online, we absolutely can do both of those things.
Thank you. When should a person who tested positive for COVID but has no symptoms be tested for COVID again?
The rule of thumb there is 90 days. Most people are expected to shed viral nucleic acid for at least that length of time. And while it should not be interpreted as saying immunity to COVID-19 lasts for 3 months after an infection, I mean, clearly people must have some level of immunity, at least in the short term, or they'd never be able to clear it in the first place. I think it is, however, very important to distinguish this situation in which they're truly positive, but the result just happens to be clinically irrelevant, from a true false positive, which is quite rare for PCR assays and usually reflects mishandling or some other kind of reagent issue. I mean, think about all the abnormal results that we don't act on because in that particular clinical circumstance, they don't actually mean anything. I think it is very important not to explain this situation to patients as false positives because it really unjustifiably erodes public confidence in testing. And I think it also feeds into this pernicious view that COVID-19 is no big deal, which I think all of us reject, having seen it affecting our own practices. If a patient does test within this 90-day approximate window against medical advice, it should be explained to them that it is likely old nucleic acid fragments rather than a viable virus. It should be also reiterated to them that is not a false positive. It's just simply that the test cannot diagnose the difference. That, of course, is why we're physicians, so that we can help them to interpret those results and understand what they mean clinically to them.
Right. That's all the questions we had. Cameron, do you have any update on today's news that President Biden has secured additional 200 million vaccine supply?
I don't have any news other than the fact that he has. When they actually arrive in Riverside County, I'll let you know. I mean, it's very promising that he's done so. I appreciate the efforts of the administration to secure it. I mean, really, both administrations tried very hard to get stuff in stock, but until it actually arrives in our warehouse, it's all it's all just a promise.
Just a promise. Uh, Dr. Kaiser, if you have a few more minutes, and Dolores, if you have any questions in the chat box, can you please go ahead?
Sure. Dr. Kaiser, do you have a few more minutes for
Yeah,
that?
I think I see 4, so why don't we just go ahead and take those?
Okay, thank you. What does the data show about vaccine effectiveness against new strains? Do you expect more large surges?
Um, for the Pfizer and Modernas, I mean, the issue is we've got several strains popping up that we're more concerned about. The UK strain appears to be covered by the mRNA vaccines, or at least with small impact to its efficacy. The real question is the South African variant. The level for surveillance for these strains is not great, and it is entirely possible that they're here and changing undetected. I believe that they are still likely to be okay. The one that's going to be a real problem, though, is the AstraZeneca one, and there's also some question about the Johnson & Johnson because unlike the Moderna or Pfizer, those are more conventional adenovirus vectors and not mRNA vaccines. The mRNA vaccines, I think, will be able to respond even if evidence actually shows up that they're not nearly as effective, because one nice thing about the manufacturer is you just go tweak the sequence and run off a new batch. I think they're going to be able to respond very well if the evidence starts to mount that they're not nearly as effective. And I think also we need to be prepared for the possibility there'll be other strains down the road. That's how it works. Whether we're going to get large surges or not, I think, what everybody's trying to anticipate is what the larger scale natural history of COVID-19 is going to be. We already have our 4 resident coronaviruses which circulate on a regular basis. It is entirely possible that additional mutations may make the virus both more communicable and less deadly, because that way it happens to infect a whole bunch more people, doesn't make them sick enough to kill them, and is therefore able to spread to other people. The natural history of the virus may end up being that we end up with a 5th resident coronavirus, which is sort of attenuated itself and then yields these outbreaks in nursing homes for which we'll need to have periodically tweaked vaccines. I think the data is too early to tell whether we're going to need to deal with large surges of those strains specifically. But I think that at least until we get a substantial proportion of our population vaccinated, we still have the potential for large surges even of the current dominant strain, and we need to be vigilant about that as well.
Okay, the next question. Can the family of healthcare workers get vaccinated under the current tier we're in?
Unfortunately, no. There is certainly a push to consider that. And if they qualify under the age guideline, if they happen to be 65 and up, they could, of course, get vaccinated simply by being a senior citizen. But as far as family of those members, that in and of itself is not currently a qualifying criterion. Again, as the vaccine supply improves, Anthony Fauci was predicting quote unquote open season for vaccines possibly as early as April. That may be a little bit optimistic. But as it stands right now, we'll try to get them in there as soon as we can.
Okay. Can individual private schools apply for a waiver now?
Yes, although speaking honestly, I think all of them are probably already open by this time. The private schools were the ones who applied first for waivers way back when that program was first offered. We got besieged with those requests early because they didn't have a union workforce, so it was easy for them to do so because they usually had to worry about only one area. During the brief period of time that Riverside County was in the red tier, and that went for about a week, schools did not have to submit any waiver request at that time. They could just open, and it is my belief that the vast majority of them have already done so. Under the state's new education guidelines, schools which are already open, and again, I would be extremely surprised if not all the private schools are open already, they can stay open even during the purple tier. They do have to update their plans and post them, but they are not going to be closed necessarily when everybody else did because they're already in operation. Right now, the mad scramble is primarily the public districts. The only one of them that had a waiver during this time was Corona Norco, and they chose not to exercise it during the height of the surge.
Okay, and the last question, is Riverside County going to participate in the My Turn state registration program?
Not only is the answer yes, the answer is we have to as a condition of being in the first wave of the Blue Cross third-party administration system. We have already starting to work on our onboarding process, and we are required to do so. So at this point in time, yes, we're absolutely able to do so. Dr. Kaur just posted something else saying this Catholic schools didn't apply for a waiver. Okay, but if they didn't open during the red tier, that's on them. However, anybody can apply right now that wants to, and we're happy to work with them on that process. They do have to meet all the current standards.
Okay.
That ends our monthly All Physician Public Health Officer Calls program. Our next meeting with Dr. Kaiser is on Thursday, March 11th, 6 p.m. Please join, and thank you very much for attending. Please use all the resources which RCMA has to offer, and be a member and make a member. Thank you, and have a nice evening.